This is Dr. Sargsyan, and we will talk about disorders of white blood cells and lymphoid tissue, and we'll talk in general about alternations and hemostasis. So hemostasis is a multi-step process that basically helps to transform blood into clot condition and again achieve hemostasis, achieve prevention of the loss of blood. But before we talk about it, we'll talk about different disorders of white blood cells as well as lymphoid tissues. It's important to know where the cells are coming from. So this is a diagram showing that pluripotent stem cell can go two different ways, and by two different ways I mean we can have a lymphoid stem cell achieved from here or myeloid stem cell. After lymphoid cell is produced, it may transform to natural killer progenitor cell, T cell progenitor, and B cell progenitor. So natural killer progenitor eventually will turn in natural killer real cell. T cells will be transformed through time as into a T cell. T cell progenitor. B cell will mature into plasma cell. Unlike lymphoid stem cells, myeloid stem cells give origin to many different cell types, and to majority of the cells you'll find in circulation. So at this point, myeloid stem cell can break down to monocytes, which will be turn monocyte progenitors, we can say, which will turn into monoblast and then monocytes. Granulocytes, this is an important concept, granulocytes can be transformed into three different types of cells, which are also considered granulocytes. So they can be eosinophils, neutrophils, basophils. At the same time, they can be considered still granulocytes because they have the granules. And as we talked before, granules can have substances inside them that may have some toxic properties for the invading organism. Megakaryocyte, it will be transferring into platelets, and erythrocyte progenitor cell will transform to reticulocyte, which is immature cell, immature red blood cells, which will turn into erythrocyte. Erythrocyte, of course, we know already that it doesn't have a nucleus. Instead of it, it has a indentation which makes it look like a donut with no hole. And again, the indentation signifies the place where nucleus used to be. White blood cells can be named also leukocytes. And again, one of the important part or components of white blood cells are granulocytes. Again, the name granulocytes comes from the notion that they have granules inside. Neutrophils, eosinophils, and basophils. So neutrophils are primary pathogen fighting cells. Neutrophils are the first responders to an invasion. Eosinophils, they will help control allergic responses and fight parasites. Also, they involve into processes such as asthma. So please remember the expression again: worms, wheezes, and weird diseases. So these are the eosinophils, what they do. Basophils release heparin, histamine, and other inflammatory mediators. And basophils, we talked about it in the past, that they can be transformed into mast cells when they migrate inside of the tissues. But again, all three types of cells have uniting feature or common feature, which is presence of granules. And granules have some type of toxic or inflammatory mediator containing granules, and the granules make them different. When we stain those cells under microscope, we will differentiate them from granulocytes, which do not have these inclusions, which do not have these granules. Lymphocytes, it's the different type of cell. So we have B cells that create antibodies and T cells that control the immune system. B cells create antibodies and they produce antibodies, and T cells will be responsible for cell-mediated immunity. So lymphocytes coming from the lymphoid stem cells, and of course they can be found in the bone marrow. Lymphocytes constitute approximately 30% of white blood cell counts. Sometimes it can be lower, but usually the number we like to see is 30. Again, there are no granules, so because of that we can call them a granulocyte. So it's B cells, T cells, and natural killer cells. So B lymphocytes, they are antibody producing cells, as I said, and they are involved in humoral mediated immunity. The second type of cell, as we said, was T lymphocytes, and they will create cell-mediated immunity. Natural killer cells are lymphocytes who have different receptors than, let's say, B cells and T cells, and they naturally kill. So natural killer cells are a somewhat different type cells from B and T cells. So how we distinguish all these three types of cells? The three types of cells or three types of lymphocytes are distinguished by their surface molecules, and by molecules we mean markers, and which certainly can be identified by use of advanced methods, and we can use something like monoclonal antibodies. But to go back to the markers or molecules on the surface, these are molecules are clusters of differentiations, and they can be grouped into categories that are specifics for cells of different origin. So let's say helper T cells, they will have CD4 markers, cluster of differentiation marker, and the effector T cell CD8 marker, and these are like really simple examples of they always brought up, but CD markers are widely used to identify the cells. So again, the cells really may look the same more or less, but what makes them different is the markers on the surface of the cells. So monocytes are the biggest cells in white blood cells. So they are approximately 6%. So 6%, and when we say 6% about monocytes or other white or even red blood cells, there is no set number, of course. It's a median of percentage of monocytes, and the number will fluctuate, and between 3 and 8%, this will be normal count. But again, it's easy to remember 6% for monocytes. So monocytes, they are the largest, and they have U shape. So, and the monocytes, they have relatively long lifespan, and it's approximately 1 to 3 days. Of course, compared to red cells, it's nothing, red cell lifespan, but however, compared to, let's say, lifespan of neutrophils, it's approximately 4 times longer, and it helps them to function longer and produce better results, let's say. So the cells also can survive in the tissues for very long time, for several months to years. So when macrophage, or when monocytes turns into the cell, into the tissue, it turns into macrophage. Again, when monocyte migrates into the cell, it's labeled as the macrophage. So when it enters into the tissues. So again, they have very distinct cell roles. They may be cells that play a role in inflammation, as well as they have antigen presenting roles to cells. So these are the cells that actually will digest the invader, and but will present it at the same time to the T cells. So the role of monocytes, macrophages, is important because they are presenting cells, and it's somewhat a different type of cell from granulocytes and agranulocytes because of their long survival rate and their ability to present antigens to T cells. This is a picture that gives you some kind of notion to understand what's happening with the cells and how they look. You can see the granulocytes, neutrophils, eosinophils, and basophils, distinct granules. Think about granules as lysosomes, and lysosomes that have some kind of substance, again, toxic to the invaders. Granulocytes, lymphocytes, has distinct nucleus, but we don't see observable granules. And monocytes are having distinct U-shape, and by distinct U-shape, I mean by distinct U-shape that they have U-shape themselves. Their nucleus have a U-shape, but this is depiction of different types of cells. On the background, you can see these pale circles, and there are the erythrocytes that do not really define, that are not defined on this picture from the microscope. So this is another depiction of transformation of myeloid stem cell already into end results: platelets, monocytes, and granulocytes, and erythrocytes. So what happened here? This cell actually comes from pluripotent stem cell, and it will turn into committed precursor cell. By committed precursor cell, we mean colony forming units. The colony forming units, they would be precursor cells that will eventually turn into the type of cell that we need in circulation. This process doesn't happen by itself. For the transformation to occur, we need colony stimulating factors. Colony stimulator factors are chemical substances that are affecting bone marrow to produce certain type of cells. The most common and most known one is erythropoietin. It's a stimulating factor that will affect bone marrow to produce erythrocytes. It's also available in synthetic form as a pharmaceutical to encourage people with some type of bone marrow suppression or blood loss secondary to one or the other factor, let's say radiation, chemotherapy. We can give this and encourage the bone marrow to produce erythrocytes. But also there are other colony stimulating factors such as thrombopoietin, which will result in, which will encourage or facilitate platelet production. So on the other hand, what else can happen to pluripotent stem cells? It may turn into lymphoid stem cells. So from lymphoid stem cells, it will turn into committed precursor cells for T-cell progenitor or B-cell progenitor. And T-cell progenitor and B-cell progenitor will turn into mature cells. Well, T-cell progenitor will work through thymus, and they eventually will turn into T-cells, and B-cells will become plasma cells. Okay, and also natural killer cells will occur from this process. So this is another depiction of the entire process, and this diagram will show you where the cells are coming from. This diagram is important to imagine or to have an understanding of what happens with cell lines when one or the other cell malignancy occurs. So again, this is the same slide. So what happens if we're having white blood cells deficiencies? We can have leukopenia, deficiency of leukocytes in general. We can have neutropenia, and by neutropenia usually the general umbrella term is agranulocytosis, because we really cannot differentiate in, especially in old-fashioned lab technique when we were using the basically the microscope and the lab technician's eyes to differentiate between types of granulocytes. So the general term will be agranulocytosis, but it would mean most of the time that we are lacking neutrophils, also eosinophils and basophils. Aplastic anemia, infectious mononucleosis are other sources for the white blood cell deficiencies to occur. So not only white blood cell disorders can affect the count of white blood cells, but something that may affect other instances such as infectious disease, viral disease, or even anemia. Let's look at the lymph node, and this is basically review of anatomy and physiology. And by looking at this, I want to give a very, very fast overview of lymphatic system. We have lymphatic tissues which will include lymph nodes, lymphatic vessels, thymus, and spleen. These are all your lymphoid tissues. They would represent the place where your lymphocytes will proliferate, mature, and interact with anything else, with other agents. So there are two types of lymphoid tissue, two classifications. It's central, or better term is generative organs, and peripheral. So by saying generative, it's the place when things or cells can be generated. And peripheral lymphoid organs are the structures where mature already lymphocytes can fight the antigens. So these are lymph nodes, the spleens, and lymphoid tissues on mucous membranes and cutaneous immune systems. But the central lymphoid structures, there will be bone marrow and thymus gland. So where your T cells would mature, and actually in thymus gland the defective T cells will be eliminated because they may react on a cell. So to recap this, generative or central ones are bone marrow and thymus gland, and peripherals is spleen, lymph nodes, mucous membrane associated lymphatic tissue, lymphatic vessels, and cutaneous immune system. Leukemia is a malignant neoplasm of hematopoietic cells. After we talked about differentiation of the cells into lymphoid stem cells and myeloid stem cells, it's time to talk about malignancies associated with those types of cells. So leukemia will involve immature lymphocytes and their progenitors in bone marrow. Myelocytic or myelogenous will involve pluripotent myeloid stem cells, and it will involve basically all blood cells that come up from myeloid stem cells. So this is the differentiation of lymphocytic and myelogenous. So lymphocytic, of course, at the end will affect B cells and T cells, natural killer cells. Myelogenous will affect eosinophils, neutrophils, basophils, platelets, and even erythrocytes. But these are two main types. Let's talk about myelocytic leukemias or myelogenous. Again, this is the diagram that represents the development of the leukemia, myelocytic leukemia. So what happens, we still have our multipotent stem cell, which will give rise to common lymphoid stem cells and neoplastic myeloid stem cells on the other hand. Little exclamation point represents the malignancy on this diagram. So lymphoid stem cells will be hopefully normal, and but on the other hand, the myeloid stem cells will give neoplastic precursor cells with all their respective commitments, and eventually this will result in abnormal monocytes or leukocytes. So again, if we go back to the beginning of the lecture to see the maturational stages, this helps you to understand how the myeloid stem cells become an abnormal abnormal monocyte or leukocyte. So, and in the origin is multipotent stem cell, which will give the origin of the rise or to neoplastic myeloid stem cells, and that will result in the development of abnormal monocytes and granular leukocytes. So this is related of some type of mutation in this line, which we will have, like in any malignancy, we will have overproduction of abnormal cells. And when we have overproduction of the cells, we are spending resources as energy on this, and other cell types that are not malignant will not keep up with this, and production of their and I was saying on the previous slides that normal cell production will decrease because of overproduction of abnormal myeloid cells. So when the mutation occurs in lymphoid cell lines, it's a lymphocytic leukemia onset. Again, the committed precursor cells will be at this time neoplastic because they came from the neoplastic lymphoid stem cells, and neoplastic committed precursor cell will give rise to neoplastic B or T cells or natural killer cells. So the same thing happened here. Abnormal cell production will increase while the normal cell production will decrease, because again the same fact that abnormal malignant cells require lots of energy. Lymphomas are malignancies that arise from lymphoid tissue cells, so either lymphocytes or histocytes. And there are two main types. It's Hodgkin's lymphoma and non-Hodgkin's lymphoma. In Hodgkin's lymphoma, malignant B cells will invade lymphatic tissues, and in non-Hodgkin's lymphoma, the B cells and T cells will be affected. So what happens in Hodgkin's lymphoma? In Hodgkin's lymphoma, one of the important features or the signs of the disease is that there will be Reed-Steinberg cells present. Hodgkin's lymphoma usually will come from a single lymph node, and often it's a localized disease, and if we have localized disease, we may treat it with radiation. If multiple nodes involved, we may treat it with chemotherapy and radiation. So let's talk about in details about Hodgkin's lymphoma. And again, what will happen, the initial presentation of Hodgkin's lymphoma, it may be presented with lymph node enlargement, a lump but will be involving a single lymph node or maybe a group of lymph nodes, and most common concern is the cervical lymph nodes or mediastinal lymph nodes may be involved, and sometimes axillary inguinal nodes also can be involved, but again the cervical lymph node involvement is very common. Constitutional symptoms start occurring. Patient will still feel sick, tired, night sweats, fever, chills, and weight loss. Again, weight loss with malignancies occurs because of the energy demands of most malignancies that can impose on the body, and that results in weight loss. So Hodgkin's lymphoma has one unusual symptom, and this is very specific and somewhat sensitive symptom, and there is really no explanation to it, but if person with Hodgkin's lymphoma drinks alcohol, and the involved lymph node will be painful. So treatment can be, again, radiation and chemotherapy, and if caught early, it's very treatable, and the results are very good in this case. The age is, this is young people a disease, and actually people will be the incidence of the disease will be increasing in 20s until 20s, and they will decline until 50s. After 50s, the incidence of Hodgkin's lymphoma will be increasing, and men, of course, more susceptible to that. There is really no known cause or carcinogen for Hodgkin's lymphoma, but again, there is some evidence that HIV infection or actually acquired immunodeficiency syndrome may increase the incidence of Hodgkin's lymphoma. To summarize, Hodgkin's lymphoma will be Reed-Steinberg cells will be present, and the patient will present with constitutional symptoms, may have only one node involved. Ingestion of alcohol may cause pain in the node, and the cure rate is relatively high if the disease caught early. So non-Hodgkin's lymphoma are neoplastic tumors, again composed of lymphoid cells. Again, the etiology unknown. Basically, we don't know what happens, but some may tie that Epstein-Barr virus presence can affect the incidence, and also with HIV, the increase have seen with HIV, and also people with immunosuppressor therapy. What happens here in non-Hodgkin's lymphoma? Malignant transformation can occur both in T or B cells, while in Hodgkin's it's only B cells. Again, there is a potential to spread to various lymphoid tissue through the body, and disease may affect many vital organs such as liver, spleen, and travel through the lymphatic system. So what are the symptoms and manifestations of non-Hodgkin's lymphoma? This again will depend on type of lymphoma, and with non-Hodgkin's there are variation of different type of lymphomas and different type of different manifestations for the disease, but it may be slow progressing disease, or it may be relatively fast progressing disease. And clinical course, and when we're saying clinical course or natural course of the disease, is approximately 5 to 10 years. So basically patient may live 5 to 10 years without treatment. Even if lymphoma low grade and fairly myeloma is a disease that presents with abnormal B cells, and myeloma is a B cell malignancy of terminally differentiated plasma cells. So what can happen in case of myeloma? Multiple myeloma is one of the most common types of plasma cell disorders. So it's relatively rare, and it's 1% of all cancers, but among the disorders of blood or blood cancers, it may increase up to 20%. So again, cause for multiple myeloma is unknown, but there is some evidence showing that immune deficits, radiation, and pesticides and herbicides can increase this. So Agent Orange is one of the causes that somewhat determined that have been causing myeloma, and there are several viruses that associated with it. Again, HIV can be increasing the risk or probability of developing myeloma. What happens in myeloma, the proliferation of malignant plasma cells happens, and what happens in this, that the abnormal cells can form tumor, and multiple myeloma will involve bones and bone marrow, and also involve the proliferation of marrow plasma cells, which can lead to bone disorders such as bone resorption, and if bone resorbs, bone will be destructed and fractures will occur. At the same time, as we know, bone, if it's resorbed, calcium just don't disappears and goes to bloodstream, and because of that, person will have hypercalcemia. So bone pain is one of the most common symptoms that occurs in individuals with multiple myeloma. So because the bone is destructed, that also will affect the production of other cells that really are not affected, the cell lines such as erythrocytes and leukocytes, because again it's abnormal B cells, but because of this, patient may develop anemia and neutropenia or a granulocytosis. Patient will experience also typical cancer symptoms such as weight loss. How can this be diagnosed? And this can be diagnosed by blood test, bone marrow aspiration and examination, and also imaging studies, MRIs. So when the diagnosis is established, at this point we can present with chemotherapy or even cell transplantation, and that will be considered the appropriate therapy for younger people, and by younger people I mean the age below 70. So the relapse may happen with all people who had multiple myeloma, and however it's possible still to proceed with treatment that will be suppressing the disease. But again, to summarize this, we need to remember that this is a disease of blood cells, plasma cells. Tumors can be formed. One of the main manifestations is resorption of the bone through proliferation of osteoclasts, and bone will break down, and hypercalcemia with all the consequences of this will occur, and patient may have complaints of bone pain, weight loss. This is Dr. Sargsyan, and today we'll talk about disorders of hemostasis, and as a part of our weekly lecture. Before talking about disorders itself, we need to define what hemostasis is. Hemostasis is a protective mechanism, or the consequence of the protective mechanism of achieving balance or protecting the loss of blood, protecting body from the loss of blood. So hemostasis is occurring by stopping somehow blood flow, and normally blood clots, and blood is usually, we know it's a fluid, and it's a viscous fluid, we shouldn't forget that, However, it will flow freely under normal circumstances when it's inside the vessels. But when the damage to vessels occurs, it will seal the broken blood vessels by a clot. So that's the normal mechanism, very briefly. And abnormally, this may be results of inappropriate clotting or insufficient clotting. So by abnormally, I mean exaggerated efforts to achieve hemostasis or insufficient effort. So when we have inappropriate clotting, as we know from the past, inappropriate from pathophysiology means excessive. So we have hypercoagulative states, and insufficient means we can't clot, and we know that the name for it will be hypocoagulative states. So if it's too much, it's hypercoagulative or inappropriate clotting. If it's too little, it's insufficient or hypocoagulative. Stages of hemostasis are the following. What happens to achieve the hemostasis, we will see that transient vessel vasospasm occurs, and this allows just very briefly to stop or slow down the blood flow outside, and then formation of the platelet plug will follow, and then it will be forming a clot, and then formation of the clot will be. So platelets are one of the key players in achieving hemostasis, and platelets are thrombocytes. Like any other cells we know in the blood, erythrocytes, leukocytes, and platelets are thrombocytes. Platelet formation is supported or encouraged or facilitated by thrombopoietin, which is made in liver, kidney, muscle, and bone marrow. So, and by muscle, of course, smooth muscle. So when we have not sufficient amount of platelets, thrombopoietin is made, and which signals bone marrow to produce megakaryocytes, and megakaryocytes are precursors of the platelets. Megakaryocytes are huge formations that eventually break down to numerous platelets. Platelets aren't as long-lived as red blood cells, and platelets live only 8 to 9 days in circulations. And when you're thinking about it, what we are in the state of crisis and we need more platelets and production will take some time, the good news is that there are lots of platelets stored in the spleen, and when there is a need, the platelets will be released. Mediators of hemostasis are chemicals produced by platelets. What happens when injury occurs? They initiate clotting by reacting with proteins that float in the blood, and also another important function is that they help platelets to clump or stick together. Clumping is usually a good process, beneficial process, because it facilitates formation of the clot and facilitate hemostasis at the end. On the other hand, the mediators of hemostasis will also stimulate wound healing and also prevent clumping also facilitate the clumping of the platelets to vessel walls. Also, they result in vasoconstriction. They support vasoconstrictions of these vessels. So there are numerous coagulation factors. Liver has an important role besides of helping with digestions and being part of GI system. It has important role of producing these plasma proteins and synthesizing them and basically supplying the blood with the coagulation factors. So this can be described as synthetic function of the liver. Again, it's a synthetic function of the liver to produce clotting factors or otherwise plasma protein. There is one factor which is called von Willebrand factor, and it's made by endothelium, and von Willebrand disease is deficiency of that factor. So you can ask a question: if we have so many coagulation factor, why doesn't all clot? Why doesn't all clot? All blood, clot? And the answer is that the plasma proteins or coagulation factors are actually circulating as inactive procoagulation. So this is a description of coagulation cascade with intrinsic and extrinsic flow. You see like how certain factors like factor 12 turns into factor 12A, which stimulates factor 11, which turns into 11A, and eventually this may result in formation of fibrin from fibrinogen. And again, these are the steps, or you see it's like a cascade, like waterfall, or cascade is a waterfall with steps, as you know. So every step the factors drop down and initiating the next. Cyclooxygenase enzymes are the products of metabolism of arachidonic acid, and actually they result in the production of mediator of hemostasis. So the good example of this is the Celebrex, which is non-steroidal anti-inflammatory drug that blocks the production of COX-2, or it's a COX-2 inhibitor, which may reduce the inflammation secondary to arthritis, and as that occurs, the pain secondary to arthritis decreases. However, when people take Celebrex, the COX-1 and thromboxane levels, which is a mediator of hemostasis or a chemical mediator of clotting, occurs or increases, I would say, as compensation, and because of that they may develop the hypercoagulative disorders. And by hypercoagulative disorders I mean increased risk for stroke, heart attack, or thrombus of any other kind. So what happened that thromboxane A2 increase of it results in the developing of the clot. So that's why the prescription of Celebrex is somewhat limited, or was very limited a few years ago, but now it's again picking up, although there are strict regulations to inform patients about possible side effects and increased risk for stroke and heart attack. However, of course, as anti-inflammatory drug, it works great. But again, if you prescribe it or if your patient already receives it, they need to know, your patients need to know that there is an increased risk for stroke and heart attack. And that's of course a consequence of increase of one of the clotting mediators, clotting factors, thromboxane A2, as a result of COX-1 metabolism, which comes from arachidonic acid metabolism. Let's look at this scenario. You are taking care of a patient who had a stroke and physician prescribed tissue plasminogen activator. And at this point, one of the patient's relatives is asking why they didn't give him heparin or warfarin instead. Of course, you know the answer, and you will be explaining this to patient and to patient's family, educating them about this. This situation, it's not hypothetical or uncommon. I can reassure you, sooner or later in your nursing practice this will happen. And there are lots of people that learn from sources like internet or other internet sources like Wikipedia or somewhere, or have a relative who takes these drugs, and they know that heparin and warfarin used for coagulative disorders, but so they would start inquiring why this, are you trying to harm my relatives? You will see this question in any way, shape and form. That's why it's important to study pathophysiology and know your answers, not because of this only, but it will be helpful for you in the situations like this when you actually trying to educate the patient and the family. So before we talk about this scenario, let's talk about plasminogen. What is plasminogen? Plasminogen is a plasma protein which is a proenzyme. As we remember, most everything in the blood that circulates in relation to clotting or coagulation is inactive. When plasminogen is converted to active form, it's called plasmin. So plasminogen activators can be formed all over the body in endothelial lining of the vessels, liver and kidneys. And by all over the body, I meant only these three sources, not literally all over the body. So plasmin will be formed from plasminogen, and plasmin is the active substance. So plasmin will help to digest the fibrin, and fibrin also will affect clotting factors such as fibrinogen, factor 5, factor 8, and most importantly prothrombin and factor 12. What's important about this entire process that the plasminogen will be inactivated by a plasmin inhibitor, or plasmin will be inactivated, which is helpful because the acting of plasmin is only localized to certain clot that we need to dissolve. It's not floating around. But before even plasminogen has a tendency, before even plasminogen is converted to plasmin, we need to activate it. And that's where tissue plasminogen activators come into play. These are naturally synthesized substances, and they can come from different sources. Again, liver, vascular, endothelial lining. So the activators will be released in response to events such as an occlusion of the vein and exercise and other factors such as certain drugs, certain vasoactive drugs, but these factors are very unstable. However, they, at the time they released and they find plasmin until, they find plasminogen and tell plasmin to convert to plasmin. I just said tell plasmin to convert to plasmin, tell plasminogen to convert to plasmin, which starts eating the fibrin and dissolving the clot. So this is how it works. Again, tissue plasminogen activator can be natural or can be synthesized and given as a medication for a stroke, and by stroke we mean the occlusive stroke, thrombotic stroke. So the question, what doctor is trying to accomplish? From here we know doctor is trying to dissolve the clot. So what's the difference between heparin, warfarin, and tissue plasminogen activator? The difference is very simple. The difference is that heparin and warfarin are acting on prevention of blood clot formation, while tissue plasminogen activator, by activating plasminogen, which is converted to plasmin, which is it's the fibrin in the blood clot, are digesting the clot or is digesting the clot. So TPA helps clot digestion, while heparin and warfarin are merely preventing it. Heparin molecules are basically cofactors that work on antithrombin. Antithrombin is a substance that can inactivate thrombin and other clotting factors such as factor 10 and some other factors. So that's how heparin works, and heparin can be synthesized by body itself, while warfarin, we already said that it affects the synthesis of the vitamin K, which is coagulation factor is that's synthesized by the liver. So when we talk about heparin, you need to remember that this is drug that can be digested and cross the GI tract and has to be given by injection, IV, or subcutaneously, and that's how it works. But again, the answer to this scenario is heparin and warfarin are preventing clot formation, while TPA will actively facilitate clot dissolution. Hypercoagulation disorders can be result of several factors. When increase of the number of the platelets, you have too many platelets in the blood, platelet aggregation, which means platelets are clumping too much together, endothelial damage, and as I talked about, this endothelial damage can result in the decrease of production of several anti-clotting factors such as heparin or even tissue plasminogen activator, and increased procoagulation factors for some reason and decreased anticoagulation factor. And by decreased anticoagulation factors, we can, von Willebrand factor is part of this type of decrease, but also von Willebrand is a consequence of endothelial damage. What can influence decreased platelets levels or thrombocytopenia? Penia is decreased number and cyto cells, so thrombocytopenia, decreased number of the platelets. Decreased production, increased destruction, and you just have too many clots forming at the same time, so we just can't provide enough platelets, even our production is normal. Also, you can have normal platelet production number, but they are having impaired platelet function. They're not functioning normally. I'd like to talk to disseminated intravascular coagulation as a disorder who is rather paradoxical because it involves hypercoagulability and hypocoagulability. So at the same time, too much clotting will occur, and at the same time too little clotting will occur. So what happens? Some type of trigger will initiate one of the pathways in coagulation, and it may be either intrinsic or extrinsic, doesn't matter. So intrinsic pathway can be activated with extensive endothelial lining damage, and endothelial lining damage can occur through injury from infection, virus, some type of immune disorder, blood stasis. Extrinsic at the same time may occur when tissue factors become activated. And extrinsic pathway is very common, and OB/GYN disorders, obstetrics complications, basically, that's the extrinsic factor. So also complications of cancer may lead to this, and also big trauma. But intrinsic pathway, it's really endothelial injury. Again, this goes with what I said before. Intrinsic pathway is endothelial injury. Extrinsic is tissue injury, of course. So both of them, doesn't matter what's the pathway, they result in thrombin generation. And thrombin generation in this case is quite extensive. And extensive production of thrombin results in clotting, thrombosis, and thrombosis can bring two things into play. When we have thrombosis with lots of vascular fibrin deposited, so we'll have ischemia in the tissues. Also, the blood cells itself will be destructed. Too much thrombin leads to plasminogen getting into the play. So plasminogen or TPAs will jump on plasminogen and activate it, which result in plasmin generation, which will result in blood clot destruction or fibrinolysis. And the products of destruction of the blood clot or fibrin, they will inhibit thrombin and platelet aggregation. So basically we have so much clot destruction because we had too much clot to deal with to start with, so we don't want any more forming because the fibrin products, that's what they're thinking, that's what they're doing, and they prevent thrombin and platelet aggregation. So this all will result in bleeding. Thrombin production also will result in platelets consumption for the clot, of course. So we don't have enough platelets to provide clots. So all this again will result in bleeding. So we have two results in here, and it's paradoxical. We have thrombosis, clotting, and we have too much bleeding at the same time. So how to deal with this? Even this is a coagulation disorder, even it seems paradoxical, and we're all thinking let's just deal with coagulation, although the coagulation mechanisms per se not effective. They work as they're supposed to work. So to treat this, it's important to treat the underlying disorders. So if disseminated intravascular coagulation occurs, then person may exhibit different signs and symptoms secondary to failure of the vital organs such as kidney, heart, lung, even brain, that clots may deposit or extensive bleeding may occur. At the same time, as I said, hemolytic anemia can happen and patient may have signs of hypoxia. So primary disease management is very important in here. Also, if patient present with excessive bleeding, important to replenish those plasma proteins and somehow correct that deficiency. At the same time, we may consider giving anticoagulants such as heparin. Again, this is very complex and critical condition, and to summarize, it's hyper and hypocoagulation occur at the same time, and the diagram describes it very well. Treatment involves A, treatment of primary disorder, and B, replenishment of lost clotting factors, and also administration of anti-clotting substances such as heparin. So, and again, the main thing about this is paradoxical. Bleeding and clotting occur pretty much at the same time. Let's talk about disorders of red blood cells. And red blood cells, as we know, the other name for this are erythrocytes. Red blood cells contain hemoglobin that's vital for oxygen transport. Hemoglobin molecule in the adult has 2 alpha chains and 2 beta chains, and by saying chains, these are polymers or polypeptides. So each chain has hemigroup, each chain attached to the hemigroup. Basically protein and hemiunit. Hemiunit is an iron atom surrounded by hemiunit itself, and iron atom is vital to connect to oxygen, transport it and release it. So oxygen binds to basically hemigroup or iron containing group. But again, there are 4 chains, each one has a hemigroup, so you can have for transportation 4 molecules of oxygen in each molecule of hemoglobin. Let's talk about production of red blood cells and how it happens. when the blood has consistent low oxygen level, it signals to kidneys to start producing erythropoietin. Erythropoietin, as a thrombopoietin, stimulates bone marrow to produce red blood cells. Of course, erythropoietin is for red blood cells, thrombopoietin is for platelets. And when bone marrow is stimulated, it will result in creation of new red blood cells, which are initially reticulocytes and then are mature red blood cells. So to answer these questions, why a man who is receiving chemotherapy for cancer may develop anemia? Because what can happen, the chemotherapy can be destructive to bone marrow, and it will result in anemia. And why men with a renal failure would develop anemia? Because kidneys won't be able to respond correctly to erythropoietin need. Kidneys won't respond when decreased blood oxygen need is present. So in this case, kidneys just won't produce erythropoietin, bone marrow is not stimulated, and you don't have red blood cell production that's needed for the patient to sustain needs for oxygen. So patient will be anemic, even though nothing wrong with his red blood cell production from the bone marrow, and bone marrow can produce enough, but kidneys don't make enough erythropoietin, so bone marrow isn't stimulated enough. Bone marrow is the site of red blood cell synthesis, so it can be stored there and released. Immature red blood cells are nucleated. They have their nucleus. Reticulocytes are still have endoplasmic reticulum, although they lost already they lost the nucleus. And mature red blood cells have pretty much nothing but their hemoglobin. Red blood cells will last about 4 months, or some say from 3 to 4 months, because it's not like 120-day passed and red blood cell checks out. And the reason they last, they are not staying forever, because their membranes become weak because of the fact that they have squeezed between the tissues through the very thin, narrow capillaries. It's wear and tear. There is no way for red blood cell to repair itself because they don't have nuclei, so it's just one-time deal. So no new components will be made. And the damage is, again, when red blood cells go through capillaries, they break because of membrane weakness. But again, membrane is not repaired because of the absence of nuclei or absence of really anything else that can help to repair the cell. So after they damaged, they are out of circulation. Most red blood cells will break in the spleen, and certain type of leukocytes in the spleen will process red blood cells, and it will result in creation of unconjugated bilirubin. So unconjugated bilirubin also can be produced in liver, bone marrow, or even lymph nodes. And unconjugated bilirubin, actually a toxic form of bilirubin, and it has to be processed into conjugated form that we all see in the bile. In this question, while men with defective red blood cells will develop hepatosplenomegaly because there will be too much to process in liver and spleen. So anyway, but the main, of course, site of processing is spleen, and red blood cells turns into unconjugated bilirubin, which is in turn processed by liver, and iron is reused. Of course, we are not losing much iron through the processing of bilirubin. Unconjugated bilirubin will be toxic, like I said, so we want to turn it into something that can be used. So too much bilirubin unconjugated will result in jaundice, and jaundice is patient will turn yellow. Sometimes it's so extensive the yellow has somewhat green tinge. Liver can conjugate the bilirubin by linking it to gluconoride, and it's used for production of bile. Again, the question is very complex here. Why would a man with liver failure develop jaundice? Because liver just doesn't process the bilirubin, and it stays in the blood and stays there, accumulates and deposited in the tissues, and you can see it in the skin or sclera of the eyes. So what happens when your red blood cells are destroyed outside the spleen? And when it happens in some capillaries outside the spleen, which can happen, some worn and torn red blood cells will give up in the vessels. So hemoglobin will be floating freely in the blood. So when hemoglobin floating in the blood is not a good thing, it will result in hemoglobinuria, and the kidney will try to remove the broken or freely floating hemoglobin out of the body, and it will result in hemoglobinuria. I tried to make the squares appropriate color, and you will see the hemoglobinuria is a brownish color. So hemoglobinuria, it's not again bloody urine, it's free hemoglobin floating in it, removed by kidneys, and it will have color of whatever is the drink of your choice, of Pepsi, Coke, Diet Coke. The most descriptive I heard was Guinness beer, and it really has that dark tinge of the stout beer, saying like Coke, Diet Coke, probably exaggeration. It's fairly dark like a stout beer. So again, I said here cola colored, but it's more dark beer colored. And in this question you can answer it, why malaria called black water fever? This is a trivia question, look up yourself, but remember what happened in malaria. This is not a test question to alleviate your fears, and I don't want you to spend too much time on it, but remember what can happen in malaria. And if you don't know, you can look it up. If you don't feel looking it up, don't look it up, but looking it up will help you remember the chain on the right side, what happened. But black water, remember where what can be called water in human organism, and black water and fever. So good luck looking this up. If you have problems, please contact me. And again, this is not
on the test. Your laboratory workup will reveal the values as following for men and women. Men have higher content of hemoglobin than women, and again, every facility may have slightly different scale for labs, but usually they will follow these numbers fairly closely. So men have 14 to 16.5 grams per deciliter, while women will have 12 to 15 grams per deciliter. It's possible to call men anemic, let's say we'll say 13, while women will be considered within normal range. Hematocrit is the amount of cellular material that comes out from spinning the blood in the tube, basically in centrifuge, and whatever is the sediment type of material. So men will have 40 to 50% of hemoglobin, and women 37 to 47. Again, bilirubin can be measured as byproduct of the hemoglobin breakdown and red blood cells breakdown, and it's usually 0 to 1.2 grams per deciliter. But that's an important lab to show the liver function, or anything else can be going on with hemoglobin and in the body. So again, these are the three important labs for blood. I would like for you to remember, and you can look at this yourself and say the ratio of normal hemoglobin to normal hematocrit is 1 to 3. Let's say your patient had hemoglobin of 14, and 14 times 3 will be 42. So you can see that lower level in men is 40. So approximately 1 to 3 ratio. If that ratio is higher or lower, that may signify changes in the blood, such as dehydration or excessive fluid volume. Again, if the hematocrit is higher than 1 to 3, that means you have too much blood cells and too little water. If hematocrit is lower, that means that you have too much water and too little red blood cells. MCV is mean corpuscular volume. It's the size of the cells. MCHC, mean corpuscular hemoglobin concentration, it's the concentration of hemoglobin, and MCH is mean cell hemoglobin. MCHC and MCH, they both reflect the color of the cell, and MCHC is more commonly used, but the more concentrated hemoglobin is, the more red it will appear. The blood will be more red appearing, and it's possible to measure. And RDW, it's red blood cells distribution weight. Some of you took statistic, but without going into statistics and talking about distribution weight. Distribution weight is the difference between sizes of the cells. If the distribution is wide, it means we have variety of the sizes of the cells, from very little ones to relatively large ones. If it's narrow, means they are uniform and they are normal. So wide distribution or increased number here will reflect that you have variety of the cells. Variety of the cells usually means that you are bleeding and producing rather small or even immature cells trying to replenish blood loss quickly. So you want this be relatively narrow or a small number, the cells being uniform. Anemias. Anemias, this is the language of anemias: normocytic, macrocytic, and microcytic. This relates to the size, and by size we mean mean corpuscular volume. So if it's normal size but patient still anemic, means hemoglobin level is low, then it will be normocytic. Macrocytic, the size of cells is huge. Microcytic is the cells are small. So you can say microcytic anemia, macrocytic anemia. Normochromic and hypochromic are related to the color or hemoglobin concentration in this case. So normochromic, normal color; hypochromic, hemoglobin isn't concentrated, or hemoglobin it's pale. So you can say normocytic, normochromic anemia, or macrocytic, normochromic anemia, or microcytic hypochromic anemia. You can use these words together all the time, depending on the size of the cells and depending on the color of the cells. And there is no hyperchromic definition because without going into too much details, you just can't have too much color in red blood cells. So it's usually normal to hyperchromic. Different types of anemias pictured on this diagram. Iron deficiency anemia will be when the cells are small because we don't have enough iron to make big cells or normal cells. Megaloblastic anemia is when the cells are huge, megaloblastic anemia, and it's usually B12 or folic acid deficiency. And big cells are dysfunctional. So you can have big cells, but you still won't have enough sufficient number of them to carry the oxygen carrying capacity, or they may have lowered the oxygen carrying capacity whatsoever. But sickle cell disease, cells are sickled in the crisis and they can stuck in places that they are not supposed to cause sickle cell crisis and pain and also ischemia. In normal cells, you can see it's like you just went to Dunkin' Donuts and brought a box of donuts and they are laying around waiting to be eaten, and there is an indentation in the middle which is roughly comparable to the side of the cell. That's how it would look. So the hole in the donut, the diameter of the hole in the donut is equal to the diameter of the side of the donut. Picture it like that. So that normocytic anemia, and you see sufficient size. They are not too many, but they kind of overlap, and that's the normocytic normal size of cells. Okay, this just describes the size of cell. You really cannot tell how many, or is it anemic or not, but most of the time megaloblastic or iron deficiency. Small cells, you see that they are too tiny even to have the indentation in the middle, although of course there is no nucleus. Causes of anemia: blood loss, wound stabbing by the knife and losing blood, versus blood loss, let's say from cancerous small tumor in the gut that bleeds continuously. Hemolysis, breakdown of the cells extensively, and impaired production, impaired synthesis. So the last one, of course, is when the bone marrow is impaired, can make enough cells. When we have iron deficiency anemia, and it's often caused by blood loss, again, it's slow bleeding tumor, wound, injury, it can be even surgical wound. Patient lost some blood during the surgery, so but this is very clear-cut cause. In iron deficiency anemia, patient will have microcytic hyperchromic anemia with increased RDW because they're losing blood, but they still have normal sized cells, and there are lots of new cells in circulations which are relatively small, and RDW will increase because of that. And it will be hyperchromic because the new cells are pale. Megaloblastic anemias are B12 anemia, which is another word is pernicious anemia, and folic acid deficiency. B12 anemia is notorious, or alcoholics are notorious to develop B12 anemia because impaired absorption of B12. Also, people with impaired GI production of intrinsic factor may have B12 deficiency. This can be resolved by, for people with alcoholism in acute state, intravenous injections of B12, but for someone who just missing intrinsic factor necessary to absorb B12 from GI tract by intramuscular monthly B12 injections. And folic acid is easy to correct by oral administration of folic acid. So both of those deficiencies will result in increased cell size, and B12 deficiency interferes with DNA production and increased size of the cells, which are not effective. So that's why patient anemic. Aplastic anemia, again, bone marrow depression. Basically, we can't produce too much because we don't have facilities. And chronic disease anemias, chronic inflammation and chronic renal failure. Let's talk about the second a little more. Chronic renal failure is resulting in decreased erythropoietin production and decreased stimulation of the bone. So in this case, we will have normocytic, normochromic anemia because our bone has normal producing capacities of the anemia. Our bone has normal producing capacities to produce red blood cells. Our bone has normal capacities to produce red blood cells. However, we don't have enough signaling to encourage that production. Iron deficiency anemia, again, hyperchromic and microcytic, and the cells will look pale and small. And polkiocytosis also may result, irregular shape. Anisocytosis, it's irregular size. Again, this is just the consequence of having not enough iron or hemoglobin to produce the cells. The cell in the middle is subtype of white cell with granules, so that's not the iron deficiency. Iron deficiency anemia, you can see anisocytotic cells and polkiocytosic cells present. Small cells, they are rather oval, or they don't have that donut indentation in the middle. Megaloblastic, huge cells. Again, folic acid deficiency or B12, I talked about it. Pernicious anemia, again, B12 deficiency, secondary to absence of intrinsic factor, which is necessary for GI absorption. And again, the cells will present the same way. Is it folic acid or B12? You really cannot tell by looking at the cell. But the red cells will be huge, oval shape, poikilocytosis, and anisocytosis, and this will be like somewhat like oval or teardrop shaped cells. Hemolytic anemias are membrane disorders, and one of them is hereditary spherocytosis, and acquired hemolytic anemias can be something like a drug may cause hemolysis and hemolytic disease of the newborn. So hemolytic disease of the newborn again was may result in excessive deposits of bilirubin under the skin because excessive presence of destruction, because of the excessive destruction of fetal hemoglobin, and the newborn will turn yellow. It's one of the first nursing interventions performed regarding this disorder in 19th century in England. And what happened, one of the nurses was very diligent about the fact that fresh air and sunlight will be only of benefit to everyone, and she would take all the babies, especially the ones who turned yellow outside, and lay them under the sun. And eventually the babies who were under the supervision of this lady were losing the yellow tinge and were developing better than others in other hospitals or wards. So one of the physicians actually wrote a paper and presented that phenomenon. However, the use of phototherapy wasn't widespread until 20th century, and nowadays you will see the ultraviolet lights in the nursery where the baby can be placed and have their own personal tanning bed and get rid of excessive bilirubin. Excessive bilirubin, of course, destroyed by ultraviolet light, so ultraviolet light will help to combat this. Again, to deal with consequences of hemolytic disease of the newborn, it's the best way so far to do is using phototherapy, sunlight, or ultraviolet light. Of course, in moderation. You don't want sunburns on baby or anyone else. So please do it under supervision, and do it if only if prescribed. Hemoglobinopathies and thalassemia and sickle cell anemia. Sickle cell anemia may result as a change in the shape. Sickle cell disease, so it's a mutation in beta chain of hemoglobin. So if hemoglobin is severely deoxygenated, and I shouldn't use the word severely, it's just deoxygenated, beta chain links, they just clamp together. They will become a long protein rod that will kind of stick through the cell and make it sickle. Basically, imagine you stuck a rod through the balloon and it's stretching it, turning into like football. So when this happens, these cells cannot travel and they're getting stuck. They cause strokes, retinal infarcts, stuck in the eyes, in lungs, and they can even block the blood flow to bones. A vascular necrosis of femoral head can happen, and also they cause painful infarcts in extremities in fingers and toes. Secondary to ischemia, of course, pain occurs, and in skin, because of not enough oxygen supply, the skin ulcers will occur. The spleen will have potential atrophy, and also chronic kidney disease will develop. Blocking the capillaries by sickled cells will result in acute pain. Infarctions, again, will cause damage to most of the vital organs, and it's somewhat related to diabetes damage, but of course the mechanism is completely different. But this is also end organ damage, and diabetes of course doesn't affect everything to this extent. So sickled cells are being destroyed extensively, so patient may develop jaundice as a result. People who have only alpha chains, or people with some fetal hemoglobin which has only alpha chains and gamma chains, are protected from sickle cell disease because neither alpha or gamma can sickle. Only beta chains can do this, and only beta chains can sickle. So some people will have certain amount of alpha and gamma chains hemoglobin. Gamma chains is a chain specific for fetal hemoglobin, and that's why they won't have sickle cell disease to that extent, even if they have a trait for it. Thalassemias are defective chains of hemoglobin, and this results because of there is a defective gene for alpha chain synthesis or defective gene for beta chain synthesis, and depends how many genes are involved, the severity of disease may happen. And when you compare alpha and beta, just briefly, you will notice one interesting phenomenon. Of course, fetal hemoglobin doesn't have beta, and that's the reason that alpha thalassemia will affect both fetal and adult hemoglobin, and in beta, it's only affect adult. So people with Asian descent may develop alpha and beta thalassemias are more prominent in people with Mediterranean origin, such as Greek and Italian. The variety of disease presentation or clinical manifestation may be quite wide in these disorders. So patient may be severely anemic and present with the need for transfusions, while in other cases there will be essentially no clinical manifestations for these people. So alpha thalassemia may result in newborn, and in newborn this can be quite severe manifestation. So when all the alpha chains are deleted and the patient only has, or baby only has gamma chains, or this is fetal hemoglobin, the HB BART created, so gamma 4 hemoglobin created, and gamma 4 unfortunately has strong affinity to oxygen. What will happen, it will capture the oxygen molecule, but it will never release it to the tissues they need it. And if this happens, unfortunately, this may result in death in utero or shortly after the birth, because this is again inability to transport oxygen. And in beta form, sometime time patient would need transfusion. Sometime patient may need even phlebotomy therapy because they need to get rid of defective hemoglobin. And so bone marrow transplant may result in the cure of some patients, but again, variety of the clinical symptoms in both disorders may vary depending on the number of the genes occurred, and some consider that these are not real anemias, but also this can result as a real anemia with hemolysis. But again, treatment may vary, and from the manifestation also can vary from death in utero or shortly after birth in severe alpha disorders versus quite in uneventful clinically course for people with beta hemoglobin deficiencies. So, and this concludes the lecture for blood disorders, and please contact me if you have any questions.